Good morning to everyone, and welcome to another session of Pediatric CME. Today we have Dr. Sneha Shalu, who is a specialist orthodontist, will be presenting on the invisible revolution in growing patients. Quite an interesting and intriguing topic. So we wonder what that invisible revolution is. Over to you, Dr. Sneha.
Thank you, Dr. Brahmana. Thank you for this opportunity. Good morning, everyone. Hi, I'm Dr. Sneha. I'm an orthodontist at AMH here. And today I would like to talk to you something that we all use every single day, that is our smile. So many people think orthodontics is simply about straightening teeth for a better experience or an appearance. While a beautiful smile is certainly is one of the benefits, orthodontics is usually much more about like properly aligned teeth and jaws can improve the chewing, speech, oral hygiene, facial development, breathing, and even the self confidence. Whether it's a child whose jaws are still growing, a teenager needing braces, or an adult considering clear aligners, orthodontic treatment can make a meaningful difference to both the overall health and the well being of the person. Today, I will show you, I hope I can bring a positive perspective about how modern orthodontics has evolved and the treatment options that are available, and why creating a healthy bite is just as important as creating a beautiful smile. So, to just start off with my presentation, this is some of the contents that I will be covering today on why the child's smile is important, what happens as the child grows, what problems can develop, and why should we treat it early. Then I can show you a few differences, like explain to you about the traditional braces and expanders that we have been using throughout. What is Invisalign first, and what are the benefits it has for the children? How the treatment works? Some two or three cases that I have done in our department. Some myths versus facts, and which is better, and what will be suitable to the child, and some take-home messages. To start with, why why is creating smile very important from a very young age? First thing, as we all know, it improves the child's confidence, and teeth has a lot to do with eating and speaking, proper bite. And also, when we have come across kids who have lisping, it is all due to the position of their tongue and teeth. And also, as you can see, the jaw growth also matters. Just to give you a more brief idea about this, how the teeth can affect your speech. So, as I said, teeth, the various sounds that is produced from the mouth is basically the relation between the tongue and the teeth. So, as you can see in this picture, when the teeth is misaligned, we have three sounds, basically lisp, the S or Z sound, which makes that is happens because of the air leak that happens between the teeth. That is more than ideal gaps that occurs in between the teeth. It happens. Then next is the third sound. Third sound happens because there is a difficulty between the tongue has trouble positioning between the teeth. So usually it happens when the lower mandible is quite back. Then is the sh sound. Sh sound happens when there is a crowded teeth. So when they pronounce words like share, care, it all goes. Now, this is most commonly seen nowadays, the difference between mouth breathing and nasal breathing. So these are some of the signs when a child comes to you, you can understand whether the child is a mouth breather. They always have their mouth open and their tongue sits very low inside the mouth, and their lips are wide apart. There is no normal competency between the lips, and there is often when they breathe, we can hear the sounds, breathing sounds like wheezing kind of sounds. So what happens? This is when they are nasal breather, when they are mouth breathers. What usually happens is unfiltered air enters in the body, and as you all know, it's there. It is high risk for colds, allergies, and infections. The oxygen absorption in their body goes low, and they have poor sleep quality. Now, there is also different phases that we have, we can see called adenoid phases. We must all have come across such patients. So when you see them, we know they have a very narrow face. Their teeth are usually very crowded. They have everted lips, and they're one specific sign you can see is they have very dry lips. You can see they are, and also they have a very slanted posture, and they have very tired eyes and dark circles. Sorry, it's taking time for the slides to move. Coming to the different jaw growths. Now, based on the growth of the patient, when we see a child, we can analyze whether their maxilla and mandible are growing in the same rate, or is there a reduction in the growth rate, or is there an excessive growth rate. When you come to the poor jaw growth, you can see usually the lower jaws are very narrow and underdeveloped, and usually can be seen in patients having breathing difficulty when they are breathing more of a mouth breather. So they have a small lower jaw, they have a very recessed chin, their faces are usually narrow, and as in all, they have a very tired and irritative mood. Now, when you come to an excessive jaw growth, that is usually we see some kids who have an excessive mandibular growth. You can always see them as a large lower jaw, a very prominent chin. They have a wide square face and a higher risk of bite problems. That is in conditions where we say the patient has an underbite, where the mandible is more forward than the maxilla. So just to explain what happens as the child grows, there is three important stages that happen. There is baby teeth, there is the mixed dentition stage, and then there is a permanent dentition stage. So the primary dentition or the baby teeth stage is usually between 6 months to 6 years. So they during that time when the dentition is proper, what happens is the child, once the child starts taking solid food at 6 months, they are able to chew comfortably. They have a proper speech development, and there is accurate spacing between the teeth when the child goes into the normal mixed dentition stage. So coming to mixed dentition stage, it's usually between 6 to 12 years. That is when the first mandibular molar comes to the final second molar comes. That is considered as the mixed dentition stage. So when it comes to this, this is where interceptive orthodontics play a high role in predicting how we can shape the child's future in regarding to their oral hygiene, oral health, their jaw growth, everything. So in this particular period, we can come to know whether the patient, we usually divide patients into three: class one, class two, class three. Class one is usually considered the ideal, where their jaw growths are normal. Class two is when either the maxilla is excessively outside or the mandible is excessively inside. And class three is where the mandible is excessively outside and the maxilla is excessively inside. So there is three forms that happens during class of children that we maintain. So in this stage, when the baby teeth goes and the permanent teeth comes, it is the best stage to correct any cross bites, if there is any constricted arches, to correct the arches. This helps them to prevent severe orthodontic treatment later on. It reduces the braces treatment time. And as we all know, after 12 years, it's considered as the permanent dentition where all the 32 teeth are out. Now, what are the problems that can develop? I'll just give you a small overview of what can happen. One is crowded teeth. Crowded teeth is a scenario where there is not enough space for all the teeth to come out. Certain teeth overlaps around, and it's mainly towards the anterior, the front region that you can see this. Then second is the crossbite. As you can see in this picture, crossbite is mainly when the lower teeth is beyond the upper teeth. So what is the problem with this? It restricts the proper jaw growth. Suppose your lower front teeth is blocking your upper front teeth, it restricts the maxillary growth of the child. Same thing happens in reverse. If there is, in case of protruding teeth, if the maxilla is excessively protruded outside, it restricts the lower jaw growth. So that's when the patient goes into a class 2 stage. And the final is the spacing. We all think extra space is good, but not in all scenarios, it's not a good thing. When there is excess space, as I told you earlier, speech can be affected. And then there is a lot of food trapping that can occur for the child, which can lead to further gum problems later on. So now comes, why should we treat this early? As I've been explaining earlier, jaw growth is one important thing. If the patient has a proper jaw growth, it can help with their posture, their confidence, the way they speak, and also it can give them a good orientation and better personality. Now, when the second is creating space for the erupting teeth. When that scenario comes again, it if we clear out all the cross bites and everything at an early age, it unrestricts the growing. The growing becomes normal, and it reduces the further complications later on that they can face. So, and the most important thing is, even though interceptive orthodontics is done, after the age of 13, braces might be needed for the complete alignment of the teeth. At that stage, the period of treatment can be highly reduced. Suppose a case goes beyond like 1.5, 2 years, it can actually come down to 1 year. Now, these are some of the examples of the traditional braces and expanders that we have been using. As you can see, there is three main appliances that are used. There is many beyond this, but this is the three main that we usually use for correcting in children between the age of 6 and 12. First is the 2x4 appliance. It looks like braces, but it is not a complete braces. In this, braces is only placed in the first four incisors, and a connection of molar band is given at the first molars. What this does is just decrowd the anterior and give space for the erupting teeth. This is an easy when the patient does not have much of a jaw restriction and there is too much of crowding. We usually use the two by four appliance. Now, the palatal expander and removal plate, both are maxillary expansion devices that are used. As you can see, the palatal expander is more fixed, and the removable expander is a removable one. Depending on the patient compliance, we choose among both. Suppose the patient is very compliant and will follow protocol, we usually go for the removable plate because it is easy in eating and cleaning. By eating, because they can remove and they can hold it in the hand and clean, it's much healthier option, and it really helps in expanding the arch. It creates space for the permanent teeth and is usually very more friendly oriented with the patient rather than the palatal expander, because in this it is fixed on the teeth. The usually the patient will need help from the parent to expand. Key is used in the slot to expand, and but this, because the patient does not have to do on their own, and the mother or the father does it for the patient, and the further tightening happens when the patient comes to the orthodontist. This has a higher success rate because it's fixed, and so it's easier to. But again, Eating is difficult for the patient. Maintaining it clean, it's quite difficult. And it can bring about a little bit of halitosis. Next, this is the most advanced option that we have now called as Invisalign First. So Invisalign is a company that's patented in America. So all their manufacturing, everything is done from America. And they are the first to introduce something called as Invisalign First, where they have brought out invisible expanders. So why is it more advanced? Is because it's comfortable. I'm sure everyone must have heard about aligners. So this is an expandable form of the aligners. They are removable, easy to clean, it's invisible while the patient, and it's more friendly to the patient because they don't, the child is comfortable. They don't feel like they've kept something in the mouth. It only covers one third of the palate, and it's easier for the person, for the patient to speak. And they change the trays every 2 weeks. So it's completely CAD/CAM technology, and I will explain further about it. So these are some of the treatment options that can be corrected with Invisalign First. So one thing is that even if you do Invisalign first, later on a correction, braces correction or an aligner correction will be needed post 13. But this, like I told you earlier, this is just a correction, interceptive phase where we can guide it to the proper stage. So as you can see in class 2 and class 3, class 2 where there is an overbite, a retrognathic lower jaw, this set of trays helps in guiding the jaw growth. It reduces the overjet. Overjet is the space between the upper and lower teeth. So the overjets get corrected. The overbite, which is the amount of coverage the upper teeth gives the lower teeth, is called as overbite. So excessive overbite is a huge problem, a huge bite problem that can also be corrected in this. Now, when you come to class 3 cases also, as you can see, a good crossbite correction can be brought about. So without much interference, a good correction can be brought on with these trays. So as you can see, it brings better comfort for the children, and it is removable. It is easier for brushing, and have everyone, yes, kids like to eat chips, apple, bite onto an apple, eat popcorn. With traditional braces, it's not possible, but with Invisalign First, it's possible for them. So they can stick to the protocol more. And as you can see, in today's world, the looks matter. So it really improves their confidence. And if they play sports like football, boxing, etc., it doesn't cause a hindrance for them. They can keep it, they can use it as a mouth guard and continue with their activities. This is just a general outline on how the treatment works. So in our department, we have an intraoral scanner, an ITRO, that is used for this. So we scan the patient. Then there is a clean check that is created that is called the digital treatment plan. So the lab sends us a plan and then we customize it according to our needs on what corrections are needed. And then using CAD/CAM technology, the the lab prepares these models and sends us the individual trays. So there is only two appointments. The first appointment, when the patient comes, we do the scanning, take the records such as photos, X-rays. The second appointment is for the fitting of the aligners directly. So once the aligners come in, we train the patient to remove and place the aligners, give them instructions, food instructions, maintenance instructions. And then we advise the patient to wear it minimum 20 to 22 hours a day. Because it's removable, people think wearing 6 to 7 works out. No, a minimum 20 to 22 hours of wear time is needed for the correction to occur. So it will be like 20 or 22 sets of trays. Just because you start off with one, you can't immediately go to the fourth set. It has to go step by step. Step one, step two, step three, step four. So, because it is highly customized, after step one, only step two will enter. If the step one movement is not complete, the step two won't fit. So the wear time is very important, and each tray can be changed from depending from 10 days to 2 weeks. And as you progress with the treatment, you can see the arch expansion happening. So this is some of the real life cases that we have done at our department. The first case you can see is a 13-year-old male boy who was presented to our department with an open bite and tongue thrusting habit. So we did Invisalign correction for the patient. It took nearly only 8 to 10 months to see the post-treatment result that you can see here. The patient was very compliant during this procedure. As you can see, it's really invisible. And the second case you can see is in classic example of crossbite, where the laterals are locked out. And this patient was a 12-year-old girl. And the total treatment time for this patient was again 10 months. And you can see the end result. So some of the myths just to clear about aligners is clear. People think that clear aligners are only for the cosmetic changes. No, I hope you guys have understood. It's more for it can also treat the various wide range of orthodontic problems such as jaw growth, breathing, posture, etc. And aligners work if only worn all the time. No, minimum wear time is there 20 hours, but better to wear it as much as possible. There is no food restrictions. You can, on aligners, you can eat anything, you just have to remove it. And they are invisible, they are smooth and clear. And people have a misconception that aligners is not as effective as braces. No, aligners is equally effective, but case selection is very important, and it also highly depends on the patient's compliance. So between traditional expanders and Invisalign first, you would think which is better. As you can see, the pros and cons are there. Both are equally good, like I told you earlier, but it depends on the patient compliance and willingness. If it's a patient who won't follow the protocol, then it's better to go for the traditional expanders. And if the patient is more concerned about looks, then it's better to go for Invisalign first. So these are some of the pros and cons. And oral hygiene, yes, is much better with Invisalign first rather than the traditional expanders. So these are some of the messages that I would like to tell you. Like I told you, not case selection is very important in this case, but expansion is always better at the right. If we intervene at the right time, we get the right result. Not every, like you see, I've had patients coming to me and saying and before ages we never used to notice all this, but nowadays all the kids are having. Yes, all the kids are having, but it is not important that every person will need this treatment, but it's always better to get an assessment done at 6 years of age with your orthodontist, so that if it is easier for us to catch if there is any growth problems that can occur, so that we can help guide them into a natural correction. And I'm sure many more advances will come. And as and when it keeps coming, I hope to keep you all updated with it. Thank you.
Thank you so much.
Thank you, doctor. Sorry if there is anything confusions in between. This is my first Zoom meeting, so
No, no, but this was perfectly, everything went very smooth. Um, if anyone has any questions?
Thank you, Dr. Sneha. This is Dr. Sana.
hi,
Just
Dr. Sunil.
yeah, hey, Dr. Sneha. Just a quick question. Would you recommend, because usually we give pedodontist regular appointments for follow-up. So would it be much for us to send to you? Would you want us to send all children to you at 6 years of age?
No, in our department, actually, pedodontics department, we work in close relationships. So anything they do send to me. But it is always advisable to send to the pedodontic department and to the orthodontic department, hand in hand, actually.
Okay, so it's like an extra. So it's like we start recommending them to start visiting anyway. First tooth eruption, you go and see the periodontist, but then for yours, an extra one at around 6 years of
Yes,
age, just to get a review as
like
well.
suppose you can see any jaw difficulties or even breathing, you feel if it's not proper, then you can always send to me to.
Yeah, sure. Thank you.
Thank you, doctor.
Dr. Sneha, I have a few questions.
Sure, doctor.
One is for the sake of all of us, most of us here attending are pediatricians. So,
Yes,
like you mentioned, the ideal age to their first visit to a orthodontist is between 6 and 8 years.
yes, doctor.
When do you suggest the first dental visit? That is one. And second is, you had mentioned in one of your slides about spaces between the teeth as one of the malalignments or that which affects speech.
Yes,
But
doctor.
isn't spaces between the teeth normally found in a child that has mixed dentition? And up to what age, up to what extent are these spaces considered okay? Um, because both the jaws are still developing. That is one. And yeah, I think after we've done this, I have a few more questions. Thank you.
Okay. So the first ideal age is actually, if you go textbook wise, the first ideal age is 3 years. 3 years is when the complete primary dentition has come into the patient's mouth. So what happens at 3 years is, suppose like I mentioned earlier, cross bites. So if you can start seeing a cross bite at that age, patient might not be compliant in using appliances, but we have certain other ways like tongue blade therapy, or there are certain other techniques that we can use to correct the cross bites, so that when the primary the dentition, the mixed dentition starts off, it is corrected. So ideally, if you see any problem with teeth developing at the age of 3, that is the correct age to actually visit textbook wise to visit an orthodontist. Doctor, your second question was regarding spaces. Spaces,
Yes.
there is different type of spacing actually when it comes to mixed dentition. So to it's it's quite extensive to discuss, but to summarize it, like normal midline diastema up to the age of 8 is considered okay. But beyond the age of 8, that is between 8 to 10 is when the canines come in. So by that time, if the gaps doesn't close, then yes, it is an orthodontic consideration. Two, there is spaces in between canine and premolar. It should be only around 1 to 2 mm. So if there is a higher gapping spacing at that time, again, it is an orthodontic consideration because the succeeding permanent teeth will not have space to come in. So that could lead to cross bites, again, jaw growth difficulties. So that's when we come in again. I hope it's clear.
That's fine. So spaces with respect to milk baby dentition, that is milk dentition, that is normal, right? That is not
That's
going to
normal.
be, that's
No.
normal. So it's only around 8 years is when the spaces are still persisting. That is a concern.
Yes. And if you,
Fine.
and in some patients where there is excessive space, you can just analyze their speech. Like I
Hmm.
mentioned earlier, Z, they have difficulty in pronouncing Z, th. When it comes, it's better to get it checked. Maybe it might be a tongue tie issue or it might be the tongue spacing issue.
Hmm. Yeah. That is very useful. Now, a few other questions I have is you had mentioned about food restrictions with braces, right?
Yes, doctor.
Can you just throw some light on what are the food restrictions with regular braces that are
With
not
regular,
there with the Invisalign? Yeah.
okay. With regular braces, see, brackets are placed on the teeth using composite glue. So we keep it in a way where we can take it out. So any kind of external pressure given, it can break the brackets. So we advise the patients not to bite onto anything, whether it's burger, shawarma, anything light, or chips, popcorn. We ask them to avoid biting. Anything, we prefer them to have soft food, okay, mashed form. So they get very restrictive in that. Not in all cases the debonding happens, but just to prevent them, we restrict their diet to soft diet. So when it comes to aligners, it is not a matter. They just need to remove the aligner and they can eat heartily.
So this food restriction continues with the children who have braces up until the braces are put. So that takes about what, a year and a half, right?
Yes.
Okay. But with the Invisalign, they can remove the braces and then eat.
They
Is
can
that
have
what you're
it.
saying? Okay,
Yes. So that is
great.
the most positive point I think people find, even
Mm.
adults, not only kids, but adults.
And what is the cost factor between these two, between traditional braces and the Invisalign?
When it comes to the traditional way, Invisalign is only one brand. It is the most, that is a patented brand that American has produced. So price range is a little higher for that. But there is, when it comes to traditional braces and the expanders, we have our own lab. And as you know, Raghavan, he's the one who handles our lab. He does very good work with that. So costing is more cost effective, but when it comes to Invisalign, we give it to the outside lab and get it. So the pricing differs. Can go a slight higher, but can be
So,
managed.
what would be the rough, if you can give us an approximate, so we know what the cost would be?
Okay. If it's for the, if you're talking about the expanders in our hospital is around in between 70 to 150. It's depending on the type of appliance that is needed. Okay. And when it comes to the Invisalign first, the costing goes around 800 to 1000 PT
Okay. That's quite a significant jump.
because
Yeah,
it comes from the outside lab.
right, right. Okay, but that's good to know so that we can, when we have to tell parents, we get an idea as to what the cost factor is.
But the braces rate is completely different. Braces, we have
Yeah.
traditional braces, the Damon, so that it can come in the same range as Invisalign,
Mm,
like 600 to 1000, 1200, depending.
okay, okay. So the outside labs also, they are in, they get it from the US, right?
Um, Invisalign is just a brand. It's in generally called as aligners. So we have aligners from different countries. Now, Invisalign is the American brand. In our hospital, we do Aqualiners, Neo Smile, which is a Dubai-based brand. We do all the aligners, which is an Indian-based brand. So we have different brands.
Okay,
The actions are same. It's just the brands are different.
fine. That's fine. Thank you very much, Dr. Sneha, for that this was a revealing lecture and session where it goes beyond the smile, where speech is affected, their confidence is affected, and uh, even their respirations based on their facial morphology. So overall, the whole health of a child depends upon how well the teeth are aligned. Thank you so
Yes.
much.
Thank you,
Anyone
Doctor.
else has any questions?
Dr. Sneha, good morning. This is
Good
Dr.
morning.
Maricel. I just have a quick question.
Yes,
What
doctor, please.
what do you recommend for children who has still permanent the milk teeth intact at 6 years old?
Sorry, doctor, I didn't understand.
The front the incisors and the lateral incisors are still intact even at 6 years old. What would you
Generally, we can
recommend?
wait up to 7 years, to 7.5 years. We can wait, but it's always better to first see the pedodontist and get an OPG done. So the OPG is an X-ray that reveals the present and the past status of all the teeth coming and going. You get a full picture. So it's easier for them to see and analyze whether an intervention is needed at that time, or they can wait up to 7 to 7.5 years of age.
Okay, thank you, doctor.
Thank you.
Dr. Sneha, Dr. Preeta
Yes,
here.
doctor. Hi,
Yeah,
doctor.
we do receive patients, I mean, parents who come with complaints of halitosis, bad breath. And
Yes,
they
doctor.
say, okay, they brush the kids' teeth, twice a day, but the smell doesn't go away. Are such patients to be referred to the ENT or to the dental department?
Dental department will be more accurate because it might be due to a decayed tooth. So some decayed tooth must have reached the root level and causing an abscess. So the smell could be because of that. Second, people only emphasize on brushing, not on tongue cleaning. So tongue cleaning is also a very important aspect that needs to be done from a very young age. So I would say dental.
Thank you.
Dr. Sneha, I'm
Yes,
Dr. Maya.
doctor.
Actually, this 3 days back, I saw a child, 4-year boy with severe snoring. The parents brought the child, telling the child is snoring.
Okay.
But looked at definitely it doesn't look like an adenoid, hypertrophied adenoid. Then I was just looking at the mouth. Anyway, this retrograde this was seen because upper jaw was little pulled out and the lower was inside. And the thing was
Yes.
there was an high arched palate. Then I told the parents it must be from this anatomy only. Man, it doesn't look like any like a adenoid. Anyway, I just want to ask you: you think that this much snoring will happen? Because both parents are very concerned. This child is snoring for the last 1 month. And the nose didn't look like no, neither the nose nor there was no tonsillar hypertrophy. Also, clinically, no, not much of adenoid hypertrophy. So, will snoring happen so much with this position of the jaws?
Yes, it's because of the tongue position. So, when it comes to such cases, we are in close contact with the ENT department. We do an interdepartmental thing where I go for the expanders or jaw correction, and then I refer to the ENT department for the breathing analysis. So, when I take the X-ray in that itself, the nasal abnormality is seen. So in that case, I also refer them to ENT, where then they help with the breathing analysis. And it actually helps. The expansion plus their treatment, it brings down the snoring and the respiration issue.
Yeah, usually we refer to ENT only, but see, looking at the anatomy, I was thinking I should refer to. So, since you spoke, in spite of referring to ENT, I think we can even refer to you
It
first.
should actually be a double reference, dental and ENT. Both has to come into play, like a multifactorial thing.
Thank you very much.
Thank you, doctor.
Hi, Dr. Sneha.
Hi, Dr. Anvita. How are you?
Yeah. Yes, Sneha, thank you so much. It was a very wonderful presentation.
Thank you,
I
doctor.
just want to know, does this aligners or Invisalign have any role in pre-surgical orthodontics?
Doctor, as because it's CAT cam, we can always use it for pre-surgical also, like for the splint formation and all. It's quite helpful.
Okay, good, because I never seen anywhere that's being used. You always go for the traditional appliances. Yeah,
Yes,
it's
but
still possible.
right now there are cases that have been published where aligners have been used along with
Okay.
surgical this thing.
All right. Okay. And in terms of time, say an identical two situations, one is you're using a traditional fixed appliance, the other one is your aligners. Is there
Yes,
a
doctor.
difference in the time with which you can achieve results?
Yes, doctor. Actually, time is again, like I told, case selection. If it's minor crowding and spacing cases, aligners is faster. But when it comes to extraction cases, aligners is slower compared to braces
Mm.
because one is a push technique, another is a pull technique. The time difference happens.
All right. Okay. All right. Thank you. Thank you so much.
Thank you.
Dr. Sneha, one last question from me.
Doctor.
Are there any contraindications for the aligners?
No, doctor. There's no contraindications as such. It is only thing is compliance of the patient
Mhm.
because it is the wear time that decides the movement. If the patient fails to wear the appliance, the treatment can go wrong.
Right.
That's the only thing.
And the minimum age where you start is from 6 years, right?
Yes, doctor.
Okay.
6 years to 60, 70, as long as you have a good periodontium, the treatment can
Right.
go on.
Right. Thank you so very much.
Thank
Any
you,
more
doctor.
questions from any of the audience? If not, we'll close the session here today. I will share the YouTube recording in the group for those who have missed it and who want to actually go through it one more time. Thank you so much, Dr. Sneha. You might expect
Thank
a
you,
lot of
doctor.
referrals from our department now.
We are looking forward to it, doctor. Thank you
Yes.
so much for giving me this opportunity. Hope I have been
Oh,
able to shed
and
some light
thank
on
you.
this.
Thank you. Thanks to Dr. Bijosh who suggested your name. And yeah, have a great day, everybody.